All
Okay,
right.
well, thank you, Dan.
Okay, absolutely. All right. So I think, unfortunately, I missed the last lecture by Dr. Schlobin, but this is the just a quick overview of pulmonary thromboendarterectomy, just more on the sort of with a focus on the surgical aspects. This is very much liberated from the talk from last year, but if you have other questions, please don't hesitate to interrupt. The surgery, I think sometimes people get a little bit confused about what the thromboendarterectomy and how it's different because of its overlap with acute pulmonary embolectomy. And even though both the disease processes and even the actual surgical procedures are similar, they are quite different. And so when we're talking about the endarterectomy, which really means that you're sort of scraping the endothelium to clean out the blood vessels, that's very different than just the thrombectomy that we see in folks with a massive PE, where you kind of just reach in and pluck it out. And so this is the typical sample you'll get from an acute pulmonary embolectomy, where you'll see like the big casts of essentially of the iliofemoral venous system, which is what these are essentially clots that are casts of, and it's a mixture of both acute and chronic clots. So in this sort of surgery, you do it on pump, and then you just open the pulmonary arteries, and you can really just reach in and just remove this completely intact. In contrast, the pulmonary thromboendarterectomy, it really is an endarterectomy, and because of the distinctions, you can't just sort of reach in and pluck it out anymore. The surgery itself then becomes quite a bit more involved and quite a bit longer. And so it's a bilateral endarterectomy. It's performed similarly through a sternotomy, but the primary thing here is to actually find that dissection plane so that you remove this thickened intima, that endothelial layer. And it's important to actually, for a couple things, it's important to, one, make sure you find that right plane, because obviously if you don't go deep enough, you won't clean the blood vessels out enough. And if you go too deep, the risk then is, of course, perforation and significant bleeding from that. And so in order to do this, the key thing that sort of sets this apart is that we use circulatory arrest to do so. And so traditionally in cardiac surgery, we frequently use circulatory arrest for thoracic aortic surgery. So when we're operating on the head vessels, we'll cool the body down to a very low temperature, and then we'll shut circulation off while we operate on things like the blood vessels to the brain. And so it is really truly a form of suspended animation, where there's no blood flow going to the brain. The brain is completely EEG silent. The heart is completely arrested. There's absolutely no blood flow going on. And then you have the clock starts ticking in terms of how much time you have before you start to have significant injury to, say, the brain or otherwise from the arrest time. And for aortic surgery, we've come up with all of these mechanisms then to sort of extend the amount of time that we can operate on the blood vessels to the brain. What's called ACP and RCP, which stands for antegrade cerebral perfusion and retrograde cerebral perfusion, meaning that we've come up with different ways to essentially continue at least some blood flow to the brain while we operate. But so traditionally, it really is that if you do traditional circulatory arrest without any of these sort of additional mechanisms, at about 30 minutes, you start to see about a 3% incidence of stroke. And then at 40 minutes, it goes up to about 7%. And then it continues to go up from there. And that's where we kind of come up with these timelines of 20 minutes at a time on each side. So the dictum for this particular operation is that we'll have 20 minutes at a time while we do so. And because those mechanisms of protecting the brain, ACP and RCP, people have certainly tried this operation using those sort of adjuncts to give them more time. But essentially, every time you do something like that, it increases the blood flow back to the lungs, and then it makes it very difficult to actually see that correct plane. And so this is done with a true circulatory arrest. There is a, there's no doubt that San Diego has been sort of the forefront leaders in really just developing the operation all told and having the world's largest experience of it. But they came up with a couple of sort of instruments that are sort of unique to the operation that aren't really used elsewhere. And in particular, it doesn't actually seem like all that much, but these forceps allow you to essentially reach down a very tiny hole that you're looking down, grab something stably without having the tips of your pickups, be too not able to reach in there and scissor or otherwise, and do the manipulations that you need to do. And then this, I don't know if you guys can see my point or not, but this this instrument labeled C, it really doesn't look like much. It really is just a suction tube, but that blunt tip that they put at the end of this catheter is actually the primary instrument that you use to do this dissection with. And it's, I think it was just by trial and error that they came out with a sort of a small yet blunt, but also instrument in order to do so. But both these pickups that are in A and B, and then this suction dissector in C are probably the two primary things that are sort of unique about the instruments as far as the surgery goes. So the surgery itself, you do one side at a time, and so this is the right side. So first we put them on on cardiopulmonary bypass, and we use that as the way to control getting their temperature down. So with the machine, we get their their temperature down to 20 degrees, and it typically takes about a good hour of cooling just to get there. Once you're at that temperature, you then essentially turn the pump off, and you actually, because the blood coming out of this venous cannula over here is draining, essentially you drain all the blood out of the body. So there's this big reservoir at the back of the pump that then essentially fills up with about 5 liters of blood. And so with essentially the blood exsanguinated from the body, we then open the pulmonary artery. This is the right pulmonary artery here. And it's when you first open that pulmonary artery and you're looking inside it, it actually doesn't look all that remarkable. So this is the anatomy of the pulmonary artery. So there's takeoffs to the upper lobe, to the middle lobe, and then down to the lower lobe. And they have this nomenclature. I think in a couple of weeks, you'll have a lecture from, I think, Dr. Boutros and Dr. Tarani about the actual angiograms and the angioplasties that they do. And there's this whole nomenclature about the sort of roadmap. But this is essentially, the incision is right here, and this is what I get to see. And then from here, trying to look down this hole into these branches that are behind the pericardium into the lung, there's the takeoff to the upper lobe up here. This is the takeoff right here to the upper lobe. And then the takeoff to the middle lobe, these branches here are coming from right here. And then the lower lobe is coming from here. And so when you first look in, it actually doesn't look all that remarkable. And then the key thing to do is to then establish this dissection plane. So you have to lift this thickened lining of the blood vessel up, the intima up. And then once you've established that plane, you then try to trace that all the way out the tree of the pulmonary vasculature. This is the same thing on the left side. So the left side, of course, the heart's in the way. And so we lift the heart up, and then as sort of in addition to not only cooling the body, we actually put a jacket that continuously keeps the heart cold as well to protect the heart from the ischemic timeline as well. So this is a jacket with a little weave basket around it that keeps that heart cold. But in a similar fashion, we make an incision right here on, this is the main pulmonary artery going into the left pulmonary artery. So that's that incision right there. And now we're looking down here. And here the view is actually even a little bit more challenging, because here's the takeoff right here of the upper pulmonary artery, the left upper lobe rather. And then looking down here, you'll then find the lingular and the lower lobe branches. And it actually, you won't actually, if you just look directly here, you won't be able to see it. But the way this operation works is once you start that plane and you start pulling up on this material here, you'll essentially kind of like the, that magician that's pulling out all the handkerchiefs out of a bag. you'll start intussuscepting the artery on itself. And so as you pull up on here, you're essentially bringing this portion of the artery up into the field. You're essentially pulling it up, and then you're trying to dissect that using this instrument to dissect the rest of the blood vessel away from that intimal lining to clean it out. Just some of the things that are when we're doing the operation. So these are all patients that have significant pulmonary hypertension and right-sided dysfunction, and just the process of putting them to sleep is can certainly be they can have acute collapse, that we saw in one of our recent lung transplants, and at risk for an arrest. And so sort of a careful, even more sort of rigorous attention in terms of making sure they don't get hypoxic at all during the process of being, undergoing intubation, getting their lines placed, and then having, essentially the pump for ECMO or otherwise, as rescue immediately available, and everybody ready to immediately cut the chest open if necessary, is important. For those in the operating room, it really works. The case looks very similar to like an aortic case in terms of when you do deep circulatory rest, the radial arterial lines often become quite dampened and actually do not reflect the true central pressure. And so oftentimes you'll see when the patients come out, they'll have both a radial and a femoral line, and they'll be discrepant. In fact, the femoral line will often read quite a bit higher than the radial line. And this is most pronounced when you're at hypothermic temperatures. And then as the patient rewarms, that difference goes away. We do routine cerebral oximetry as well, as a way of sort of monitoring, any sort of suggestion that there is increased risk for a neurologic event while we're doing the operation. Sort of the concomitant things that go along with having right-sided dysfunction. Tricuspid regurgitation, RV dilatation, all of that is very common. PFOs are also just common in general, let alone in pulmonary hypertension patients. But in pulmonary hypertension patients, sometimes it's actually thought that you should leave it open, particularly if you think that there's going to be ongoing pulmonary hypertension, because it may be a significant, even though it's a cyanotic shunt, may be a significant source of systemic blood flow by moving that blood flow to the left side. In general, the dictum that San Diego has found, as much as the high degrees of pulmonary hypertension, in particular high elevated PVR, significant right-sided dysfunction, in general, that indicates that the patient is at much higher risk. There really is no level at which is in general thought to be a contraindication. And so even when the right, and I have a case here, one of the very first cases I did that was a prime example of that, that even in patients who seem to have just profound right-sided dysfunction can have substantial benefit from this operation. And then along those lines, because you'll often see a fair bit of remodeling after the operation, even if they have severe tricuspid regurgitation going into it, very often as that right-sided, as the obstruction is relieved and the hypertension improves, the right side will remodel, and then that tricuspid will actually remodel as well, and the regurgitation will improve. When we're doing the operation, so there's this constant sort of concern about going deep enough but not going too deep. And there are all these sorts of different signs of when you've done one or the other. One of the simplest things that we do in the operating room is once we've completed the endarterectomy, we'll give the patient a Valsalva. They'll essentially, in sort of a reverse sort of air embolism, they'll inflate the lungs to pressure, and we'll actually look for bubbles coming backwards into the pulmonary arterial tree. And that can certainly be a major issue if you do see it. And there are different ways to treat it when you do. So on the lung side, you could put essentially a balloon, like a bronchial blocker or something like that, to essentially trap what's bleeding into the airways into that segment. From the arterial side, you can actually, you can either temporarily ligate it by putting a ligature around it on the outside, or you can even actually just essentially functionally do an infarct, essentially give up on that segment and seal that off by either with a glue embolization of it. Because there's a significant risk of reperfusion edema once you've cleaned the lungs out, in the recommendations is to keep the patient intubated overnight. And there are some programs that are sort of pushing that in terms of selecting out patients that could be extubated the same day. But because it is not a simple thing to be able to pick those patients out, we have sort of, from a more conservative standpoint, left them all intubated overnight. And then from a tidal volume standpoint, we actually, in contrast to sort of what's the typical, 6 to 8 per kilo and so forth, we actually try to keep the lungs more inflated, and actually they recommend that it's 8 to 10 per kilo from the tidal volume standpoint to keep that essentially the airways stented open. As soon as possible, once it is appropriate from the chest tube, you start anticoagulation, very similar to like valve surgery or VAD surgery or otherwise. The interesting thing is very often, saw this on a couple of our patients already here too, where they'll come out and they'll have some, there'll be an improvement in their PVR, but it won't be as robust. And then there's often a steady improvement over that first 24 hours when not only the PVR improve, but also any sort of VQ mismatch and hypoxia will improve as well. Talked about this reperfusion edema. When it does happen, the thing to remember, so very different from every other patient than most of the patients in the cardiovascular ICU, where it's all focused on sort of optimizing cardiac perfusion. This is one where you actually don't want the cardiac output. You actually want to minimize that reperfusion, that sort of perfusion stress on the lungs. So to the degree that the rest of the body, the kidneys, the heart, the brain, and so forth, can tolerate a lower cardiac output, that's actually beneficial from the lung standpoint. And this is true both in the CTEPH patients and as well as the lung transplant patients. So it's aggressively diurese. You don't want to see cardiac outputs, above 2.5. Typically, we target cardiac outputs in the 2.2 range to try to minimize that reperfusion stress. And then there's some question about lowering the tidal volumes and giving steroids as well. But in general, it really just don't over treat with cardiac output. And so sort of the traditional things where you see sort of this knee-jerk reflection to start Milrinone and so forth are to be avoided. When we're out and selecting patients, it's this is still an operation that is a very fairly uncommon and probably unrecognized disease entity overall. I think, San Diego has done a remarkable job at not only demonstrating that this is a true problem and that it can be done well, but they essentially set a benchmark for good outcomes that is, outcomes that for these really sick folks are just as good as, say, like routine, coronary surgery. Selection is important. The most sort of the standard sort of benchmark is a mortality, 1 year mortality of less than 5% is considered, to be, good. But clearly it's possible to achieve much lower sort of mortalities. In terms of like the risk factors, the things that particularly can be a concern. So when the PVR, that pulmonary vascular resistance, is quite a bit higher. So in the really high range, so typically you're talking, so this is in the 9s, but if you're in the Woods units where it's above 10 or 11, in that sort of range, there have been another series that show increased hospital mortality just when they're at such an advanced stage of disease. And so it'd be nice to certainly, identify these patients earlier to minimize their risk, but it's not certainly contraindicated at that level either. Some of the things that you would typically think would be problems such as obesity, age, redo surgery have not been shown to be significant increased risk factors. So I have a couple of cases from before. This is the first one here is just a sort of a relatively straightforward case. 60-year-old gentleman with a history of prior PE, and then 4 years ago was originally diagnosed with the PE, was started on Xarelto, but then sort of lost the follow-up and then was off of it, but had gone back to work, was doing fairly heavy-duty work until he started to have some pre-syncopal symptoms. And when he came back in, it was noted to still have significant clot burden, but lots of findings of not only the central clot burden, which is often the red herring in CTEPH, but these findings of chronic disease, such as these webs and bands and so forth. And so this is what is often is the case. This is, this almost looks like an echo that's been flipped backwards from what we typically are sort of focused on. But here you can see that the left ventricle here is actually robust, and the right ventricle here has been blown out and is quite dysfunctional. And then these are some older patients. So the diagnostic study of choice is a VQ scan to look at defects in perfusion, which you can see in so sort of what's typically described as this moth-eaten type pattern. But more recently, the use of these dual energy CT scans, where they can actually use it's just a regular scanner, but they scan it at I think it's at 2 different energy levels, and then based off of that, they can actually get a differential in terms of the tissue that reflects the perfusion. And the dual energy CT scans actually seem to be a lot more sensitive, and it provides that sort of 3D info that we're more used to seeing, because a lot of times on these VQ scans, if they don't have just a sort of the standard moth-eaten appearance, there may just be a general overall sort of opacity, and a lot of times the VQ scans are sort of misinterpreted, even in folks that have fairly advanced CTEPH. So then the sort of gold standard then to diagnose things is then a left heart cath. And the left heart cath actually requires a fair bit of expertise to do as well. Where I was at my former institution, these were sort of the images that I would get, where essentially it was just a one-time flush shot of the lungs. And just you would get a sort of a brief roadmap, whereas now Dr. Boutros and Dr. Karani are doing these super selective, where they're injecting each different of the branches of that roadmap, and you can really get a much better view of what the actual issues are. But nonetheless, this was his pulmonary angiogram, and you can see just severe pulmonary hypertension, a marked elevation in the pulmonary vascular resistance. And then even though he only had sort of a mild to modest but relatively normal functioning LV, marked reduction in cardiac output related to his right heart failure. And then this is the same thing, just at the time of surgery. You can see that within the RV really is in bad shape. And so then this is what happens. So that surgery, just as we kind of described before. So opening the right side, you see this is the part that always looks impressive on the CT scan, where you see this large central clot. But this is, again, just oftentimes more of a red herring. And really the issue that's affecting the pulmonary vasculature, the resistance rather, is the blood vessels at the tail end. It's all these distal vessels going out to the capillaries. And it's this portion that's being cleaned out that really is what does the most benefit for the patient. And this one is, this was sort of a long-standing chronic, but still with a lot of residual disease that looked, fairly impressive from doing so. And then almost immediately, you can start to see that that right side starts to improve. It's no longer completely down. The tricuspid regurgitation as a marker of RV dysfunction improves as well. And then perhaps more remarkably is getting that pulmonary vascular resistance, that pulmonary hypertension down, and the pulmonary vascular resistance down leads to improved forward flow. So as a more sort of striking example of just how much, of how bad this could be, this was kind of an unusual case that originally got referred to me just for RV failure. And he had this sort of, he had this diagnosis of what's called ARVD, or arrhythmogenic RV dysplasia, which is a congenital issue where they have, frequent arrhythmogenic events, but unfortunately is also a bit of a diagnosis of exclusion. And so he carried this diagnosis. He'd had an ICD, he'd had multiple ablations, multiple shocks, and he was just thought to be at the end stages of RV failure and was being referred for a transplant. And then it was just, oh, by the way, in the background, he does have this history of a hypercoagulable state and a remote history of a pulmonary embolus. And then he had the usual smattering of comorbidities that unfortunately go with chronic disease. So fairly symptomatic, pretty severe. And then interestingly enough, if you look at this, it's a very mixed picture. So number one is mean pulmonary pressure was in the low 20s, which I guess maybe by the newer definition, but is not really significant pulmonary hypertension. And despite that, though, remarkably low index, and then with that, this sort of moderate elevation in the PVR. And the question is what's going on? And this is sort of, this was his VQ scan, and this was read essentially as no findings, as suspicious for pulmonary embolism. And I think it's because I think most radiologists are sort of trained to look at this and solely look for the acute defects. But when we had the opportunity to have the folks from with the suspicion that maybe there was some CTEPH, and had the folks from San Diego review it, they said, oh well, in fact, maybe there is some segmental lesions over here. Maybe there's there's general paucity on the left side compared over here. It looks like the lower lobes really are not seeing the perfusion you would otherwise typically expect. So they actually thought that in fact maybe this was essentially an underread interpretation. And then when we did the angiograms, you can see that in fact there are this branch should then go down and come down in here, and it's missing this section down in here, and very similarly down here on the left side is missing as well. And so it was a very interesting sort of question for us, because it was, again, this was a guy that was essentially referred to us for RV failure, needs a heart transplant, and yet there's some concerns that maybe there's some issues going on in terms of pulmonary disease, but he didn't have sort of the with the sort of what would be considered for a heart transplant borderline elevated PVR. So typically for heart transplants, a PVR above 6, and his was, just at that border would be considered too high. But it didn't all add up and make sense. And so after reviewing, with the angiogram and so forth, and reviewing it with San Diego, we ended up coming up with this plan to explore him for a thromboendarterectomy, with the expectation that if that was not the case, we were actually going to then put in an RVAD, a temporary RVAD, and then move forward with either transplant or an artificial heart for the guy. And so with all the sort of things that we had already discussed, we did move forward, and it was quite remarkable. Very much like that angiogram suggested, significant obstruction down to the right lower lobe, as well as on the left lower lobe side, and then all the sort of findings for severe RV dysfunction. And so we kind of hedged our bets. We did both the thromboendarterectomy as well as set them up for a temporary RVAD to at least get them through the stress of that, and then potentially urgently transplant him as well. So he was essentially set, graft was sewn on for a temporary RVAD. And here's that specimen. And so again, looking inside the blood vessels initially, they essentially look normal. You can just see some sort of mild thickening, but there are essentially blind areas now when you're going down into that lower lobe. And so even though like centrally we were not able to find significant obstructions, those areas that were identified on the angiograms were quite significant. And so, this specimen is not sort of like the typical, like the specimens that we're finding in the folks with a lot more proximal disease. But nonetheless, just removing these, clearing out both lower lobes had a profound difference on in terms of his RV dysfunction. So, the procedure finished, but even though the RV looked like it was still weak, we weren't on a whole lot of support. Amazingly, his cardiac output shot up quite a bit higher than you would expect. And he actually did not seem like he needed even RVAD support just to get through the large operation. And so we took him off and closed him up. And then he just made just a remarkable steady progress over the next couple of weeks, and then went home. And it's so if you then go back, and say, oh, this doesn't really show all that much, but then you compare here to here, you now start to see, oh, in fact, there was, sort of relatively more significant, perfusion abnormalities. You can definitely still see some degree of patchwork in terms of perfusions, but this was actually formally read as no change. But nonetheless, his clinical functional status continued to improve, and then to the degree that we then took him back off of the list for heart transplant. I think that is the folks that I have. You guys have any questions?
From a nursing perspective, I'm really blown away. I really appreciate you sharing this with us.
Yeah, I hope to have like more of like our own recent patients. I just didn't have time to put it all together, but I'll do that for the next time.
Well, hopefully in once we take care of COVID and move back to the normal life, then we can reinstitute our PH therapy. PH education day, and plan to hopefully have it maybe in the fall of 2021, and then we can share some of our experiences. But as of right now, we've done 4 PTs, and hopefully we'll do another one at by the end of the year. So and so far so good. So very exciting.
Yeah. Well, thanks, Ben, for the presentation. For somebody who's never seen the surgery, even for a pulmonologist, it's really fascinating to see how much work this is, how complex a surgery this is. It sounds even more complex than lung transplant, really. It's really good to have a perspective, and thanks for sharing the cases.
And I have to say, you make you just make a little incision and find the plane.
I must say, like the first time I saw a circ arrest case for aortic surgery, it is a remarkable thing when you realize what's going on. Mm-hmm. like for cardiothoracic surgeons, there's sort of this saying that the pump is your friend. So anytime, things really going bad, not going the right way, our first thought is get them on pump, get their blood flow supported so that you can take care of them. And then this is like the one operation where, somebody says, turn the pump off, and does the machine stop whirring? But then you actually just start to see, just by gravity, the blood drain out of the body. It is really a crazy thing to do to somebody.
Yeah. Yeah. Well, we're glad we're glad you're there doing it. But it is something that's really cool, actually. And I mean, I remember seeing the first one at UCSD, and it's kind of it's a little bit weird because you realize there's that person in front of you with no blood in it. So, but it's very cool, super cool. So, well, great. If no one has any questions, Cindy recorded this